Okay, in this video we're going to talk about rheumatic disorders. So arthritis is the first set of diseases we'll talk about. It's the most common disabling musculoskeletal disorder in the US. About 46 million people afflicted with this disorder, and increasing age is one of the major risk factors for a lot of forms of arthritis. Now, osteoarthritis is a local degenerative disorder, and it's associated with aging and wear, as well as from repetitive stress. It's the most common form of arthritis in the world, and it's characterized by a loss of articular cartilage. The cartilage can calcify, which wears the underlying bone, and the formation of bone spurs can occur as well. Can be non-inflammatory, and typically the weight-bearing joints are most often affected. So think of the osteoarthritis form as being just from overuse. Now, the manifestations can include localized joint pain, bony enlargement, morning stiffness, and the Heberden and Bouchard nodes. Treatments aimed at improving the function of those particular joints with physical therapy and by reducing pain. Now, this is showing just those Heberden and Bouchard nodes, and you can see that with osteoarthritis, there's an inflammation in these interphalangeal joints. The Heberden nodes are the ones that are in the distal interphalangeal joints, and the Bouchard nodes are the ones that are in the middle interphalangeal joints. Now, infectious arthritis differs because this is actually an invasion of the synovial membrane with bacteria, usually by the way of the bloodstream. Both the synovial membrane and the cartilage deteriorate as a result of this inflammatory response. Manifestations include localized infection and systemic manifestation of inflammation. You get warm, red, very swollen joints, and a limited range of motion due to the inflammation and pain. Treatment for this is typically antibiotic therapy for weeks, 4 to 6 weeks, and therapeutic joint aspiration in order to relieve some pain, or some of the inflammation rather. You might also require arthroscopic and surgical drainage. Now, rheumatoid arthritis is actually an autoimmune inflammatory disease, possibly related to genetically predisposed individuals. What we find here is that inflammatory response leads to an accumulation of immune cells and infiltration of the synovial membrane. Granulation tissue forms over the articular cartilage, and you get a loss of cartilage, which can lead to bone erosion, bone cysts, and fissures. Now, the classic presentation with rheumatoid arthritis is bilateral symmetrical polyarthritis. So what we find here is that it's going to occur on both sides of the body. It will be symmetrical in the sense that identical joints are afflicted on right and left. And we see diffuse musculoskeletal pain as well. Disease-modifying anti-rheumatic drugs are aimed at achieving long-term control, and they're recommended early in order to minimize later damage. So the treatments include non-steroidal anti-inflammatories as well as corticosteroids. Now, systemic lupus erythematosus is this chronic multi-system inflammatory autoimmune disease where we get periods of exacerbation and remission. We'll talk about this more so in the skin chapter. However, it also affects joints. So what we get is B lymphocytic overactivity, and the most common features are arthralgias, so a lot of joint pain, synovitis, and then this is associated with skin lesions and butterfly rash. It's diagnosable through a positive ANA test or anti-nuclear antibody test. So you're looking for antibody titer. And the treatment includes topical corticosteroids and avoidance of sun, as well as non-steroidal anti-inflammatories and anti-malarial drugs, and just generally immunosuppressive agents because this is an autoimmune disease. This is showing the characteristic malar rash you see with systemic lupus erythematosus. Lupus means wolf, so it looks like the rash or like sort of the fur pattern on a wolf's face. And then erythema is the redness. You can see that this is that erythema, right? So it kind of has that sort of wolf fur pattern shape to the rash. Now, not all forms of systemic lupus erythematosus present with a malar rash. However, this is pretty characteristic of SLE. Now, Scleroderma is a multi-system inflammatory connective tissue disease where we get a thickening and deposition of collagenous tissue that results in severe fibrosis. It's idiopathic in the sense that we don't really know what causes scleroderma. However, it does present with Raynaud's phenomenon, which we saw was a decrease in the blood flow to distal extremities, polyarthritis and sclerodactyly, as well as a macular rash and internal organ involvement. Ankylosing spondylitis is actually caused by a fusion of inflamed vertebra, and it's actually an arthritis of the sacroiliac joint that involves the axial skeleton and can sometimes involve peripheral joints. Now, it seems to be genetic because we actually have a positive HLA marker here, and the manifestations are lower back pain and severe morning stiffness. This eventually progresses up the lumbar spine through the thoracic and cervical vertebrae until, due to inflammatory reactions, the vertebrae becomes one large fused, calcified column of bone. Now, it's treated with stretching and exercise and non-steroidal anti-inflammatories, basically drugs that inhibit inflammation because it's the inflammation that contributes to the progression of this disease. So this is showing the typical posture of ankylosing spondylitis. It typically affects males more than females, and due to a fusion of the vertebrae, they end up with this kyphosis type of posture. Now, reactive arthritis is preceded by urethritis, cervicitis, and dysentery. So we're saying that, basically, due to these infectious etiologies, it can lead to, joint involvement, and many of these occur in genetically susceptible individuals. The manifestations are like oligoarthritis, that appears 2 to 6 weeks after an infectious episode. And it's treated with non-steroidal anti-inflammatories, intra-articular corticosteroids, and different immune-regulating agents. Now, acute rheumatic fever is also an inflammatory disease, but it follows this beta hemolytic group A streptococcal pharyngeal infection. So you think of like strep throat. What can happen is rheumatic fever occurs later. And the onset's 2 to 6 weeks after the infection. What happens here is we get cross-reactivity of immune cells with proteins and target organs, and due to the deposition of these proteins within these tissues, it leads to polyarthritis, carditis, fever, and it can even damage the heart valves, which we talked about back in the cardiac chapter. Treated with aspirin, non-steroidal anti-inflammatories, antibiotics, and corticosteroids. Basically, the key here is actually trying to avoid too severe of a streptococcal infection, so that you can help prevent rheumatic fever. Now, postparasitic disorders can also lead to articular involvement, especially Lyme disease. Lyme disease is actually caused by a spirochete called Borrelia burgdorferi, and it's a tick-borne spirochete that's carried by the deer tick. Now, after the bite of a deer tick, this microorganism is introduced to a host body, and we get an inflammatory and autoimmune response, because the antigens on the surface of this particular microorganism can trigger autoimmunity. So what we find here is that the tick bite produces red macules and papules, accompanied by flu-like symptoms, and this leads to musculoskeletal, neurological, and even cardiac involvement. The treatment for this is oral and parenteral antibiotics. Now, other joint dysfunction that's secondary to diseases could be things like neurovascular disease. We understand that neurovascular etiologies as a consequence of things like diabetes or peripheral neuropathy. This can lead to joint derangement because of the fact that if you can't feel your joints, then you're more likely to injure them. Now, these are related to chronic diseases like diabetes and hemophilia, and other things like metabolic diseases that can lead to the deposition of uric acid, as you see in gout, and all this can damage joints. Now, psoriatic arthritis is actually an inflammatory arthritis that's associated with psoriasis, which is a immune response. And the peak age of onset is like 30 to 55 years of age. There are certain genetic factors like T lymphocytes and macrophages that infiltrate the skin and joint tissue. These release inflammatory cytokines that cause inflammation within those joints, and that leads to damage of the joint tissue. Now, it's characteristic by asymmetric oligoarthritis. So with psoriatic arthritis, this differs than rheumatoid arthritis in the sense that it's asymmetrical. So you might have arthritis only in the right knee joint, not both the right and left. Therefore, it's asymmetric. Now, it's oligoarthritis because it affects many joints, and you see this also affects soft tissues and leads to things like enthesitis and dactylitis. Now, the treatment for this is actually non-steroidal anti-inflammatories as well as corticosteroids, keratolytic agents, and light therapy, as well as immunosuppressive therapy. Because this has an immunological origin, immunosuppression agents are effective against psoriasis and psoriatic arthritis. Now, enteropathic arthritis is actually an articular manifestation due to inflammatory bowel disease. We talked about this back with ulcerative colitis and Crohn's disease, where as a consequence of these basically bowel diseases, we get immune cross-reactivity with bacterial antigens, and these deposit within joint tissues, causing peripheral arthritis, which can also involve muscle and bone. Now, this may involve skin, so you can get an ocular manifestation, so you might get rashes or visual disturbance. But again, because this is an immune-related etiology, it's treated with immunosuppression agents. Neuropathic osteoarthropathy is basically called Charcot joint. This is actually where you get bone and joint abnormalities due to loss of normal joint position sense. Now, you see this commonly due to diabetes because of peripheral neuropathy as a microvascular consequence of that disease. But ultimately what happens is that if you can't feel where your joints are located, then you're more likely to injure them, and that injury can lead to swollen, deformed, and unstable joints, and it's treated through immobilization as well as less weight bearing. Ultimately, because this is a secondary consequence of another disease, you have to treat the neuropathy, or basically nerve dysfunction, in order for someone to prevent Charcot joint from forming. Hemophilic arthropathy is essentially where from hemophilia you get a leakage of blood within the joint cavities that stimulates synovial proliferation. This leads to chronic inflammation and the release of proteinases, which cause changes in cartilage, which are less resistant to stress, and therefore you get degradation of the joint itself. The acute stage of hemophilic arthropathy is basically where you get bleeding the joint. The second stage is repetitive hemorrhages, resulting in chronic synovitis. And the third stage is actually a destruction of joint integrity. The larger joints are more commonly affected because they just typically are more prone to stress that can lead to bleeding. But the treatment for this is just to enhance clotting. So as long as someone has their hemophilia under control through like frequent blood transfusions, as well as education and prevention of joint deformity, basically these individuals can prevent arthropathy that can occur as a consequence of the hemophilia. Now, gout, you guys have heard about before, it's actually a heterogeneous disorder that's actually due to a disturbance in uric acid metabolism. Now, uric acid is one of those byproducts of protein metabolism, and if in high concentrations, uric acid can actually form crystals, especially within joints. Now, the increasing risk with age, however, it's characterized by hyperuricemia and urate crystal-induced arthritis. Now, the recurrent attacks of this are due to tophi, essentially the accumulation of crystals within joints, but this can be caused by renal impairment and the buildup of uric acid calculi. Now, looking at the joint itself here, what we find is that uric acid crystals might start to build up within the joint cavity. This leads to basically an increase in the resistance along that joint, to get more friction, which damages the articular cartilage and possibly even the underlying bone. This stimulates an inflammatory immune reaction, and these leukocytes that are attracted through chemotaxis to the crystals try to degrade these crystals, but unfortunately they actually get ruptured as a result too, causing the release of additional cytokines and enzymes, and it ends up being a positive feedback type of reaction that eventually leads to degradation of the joints. Now, it especially affects the interphalangeal joints and the distal extremities. So the treatment for gout is essentially aimed at reducing the inflammation and lowering the amount of uric acid you find in joints and within your blood in general. Colchicine can be used to prevent recurrent attacks, and there's different medications that correct hyperuricemia and prevent gouty flares. Depending if it's sort of genetically related or if it's due to diet, you want to basically educate somebody on the origin of uric acid dietarily and then help them prevent those sorts of foods. Now, other pediatric joint disorders include things like non-articular rheumatism. This is an interesting one. This is the one we call growing pains. So it's a common soft tissue syndrome with nocturnal pain. We call it growing pains, however, it has nothing to do with growth. Rather, it's due to the hypermobility of joints that can lead to pain. It's especially prominent during sleep or as children kind of become more restful because they're more aware of this joint pain. Now, it's not associated with growth directly, but you find it in kids because of the hypermobility of their joints and due to the fact that kids are just generally more active than adults. So they're more prone to non-articular rheumatism. But again, it's a misnomer because it has nothing to do with growing.